This is Brent of the Brookbush Institute, and in this video we're bringing you another manual technique. Now if you're watching this video, I'm assuming you're watching it for educational purposes and that you are a licensed manual therapist following the laws regarding scope of practice in your state or region. That means athletic trainers, chiropractors, physical therapists, osteopaths, licensed massage therapists. You are likely in the clear to do these techniques. Personal trainers, this probably does not fall within your scope of practice, although you might be able to use the palpation portion of this video to aid in learning your functional anatomy in an educational setting supervised by a licensed manual therapist. Now, before we place our hands on a patient or client, it is important that we assess and have a good rationale for doing so. And of course, if we're going to assess, then we should be reassessing to ensure that the manual technique we're using is effective and we have a good rationale for continuing to use that technique. In this video, we're going to go over static manual release of the upper trapezius. I'm going to have my friend Melissa come out. She's going to help me demonstrate. Now, all of our manual release techniques follow a very similar protocol. Step one is to be able to differentiate the target tissue from the other tissues around it. Step two is to think about any tissues that might be injured or insulted by compression that are around the target tissue. Step three is we get a little extra bonus for knowing our trigger point sites that'll help with our accuracy of our palpation and for finding the points that we need to release. And step four is thinking about patient and practitioner position so that you're in a good position to be able to hold the release technique long enough to actually get the desired result. Now, palpation of the upper trapezius, if you know your functional anatomy, is not that challenging, right? The upper trapezius is a very superficial, flat muscle that runs along the whole posterior and lateral aspect of the neck into the spine of the scapula and all the way down onto the acromion shelf. Essentially this, well, what you're seeing is skin, but just underneath the skin is the upper trapezius. If you want to get a little bit more detailed, you can kind of feel through here, and you'll notice this bony ridge that goes all the way to the shelf of her shoulder. When I talk about the shelf of the shoulder, I'm talking about that bony shelf where you don't have any muscle, regardless of how big your deltoids are. This is your acromion shelf. And then this right here is the spine of your scapula. I can kind of palpate in through here fairly superficially, follow that all the way up into the neck, and if I let myself kind of fall off this meat on the side of the neck here, I get an idea of how thick and how the fibers course for the upper trapezius. You can kind of feel how flat this muscle is. Unlike the levator scapula, which we talked about in a different video that's very ropey and bundly, this muscle has like a density, but no ropiness to it, for lack of a better term. So once I have a good idea of how my upper trap feels, I need to start thinking about, well, is there anything else in here that I should worry about before I start strumming these fibers? And the answer is yes, we do have one potential issue, and that's if I get really, really anterior on the upper trapezius, I start to fall right along those transverse processes of the cervical spine, which means I have just a little bit of concern where if I press down really, really hard, I could stretch the brachial plexus, and that could be problematic. It's going to be very uncomfortable for the patient or client. Number one, it might give them burning or tingling or a numbing sensation in their hands. And if they are somebody who has had a history of radiculopathy, you could flare them up a little bit. So let's be careful. Let's make sure that we stay a little bit more posterior and that we don't search from the anterior aspect of the neck. And then make sure when we're pressing, we do keep in the back of our head that, hey, this is a superficial muscle. I don't need to sit here and drive down with all the force I have or like sink an elbow down into the neck. Like my thumbs and a little bit of pressure is going to be fine. Considering the direction of these fibers, I'm going to assume that the direction goes from the spinous process ligamentum nuchae and external occipital protuberance, which is the origin of the trap, straight down to the spine of the scapula here. To strum those fibers, I'm going to need to go this way, right? So either from superior lateral to inferior medial, or from inferior medial to superior lateral. And remember I told you that you get bonus points for knowing where the trigger point is? The trigger point on the upper trap is almost right down in the middle of this meat here. I know you guys can walk up to somebody and kind of know what I'm talking about, where you got this like little triangular section of muscle right here on the side of the neck. Right down in the middle of that tends to be the common site for the trigger point in the upper trapezius. If you start palpating across this way and looking for the most dense fascicles, right? We'll assume those are the most overactive fascicles, and then you can start moving from distal to proximal towards the neck to find any nodule, any increased acute point of increased tissue density, and I feel one right there. How's that feel? A little more tender than the rest of it, right? All right, so this is where I would hold my technique. And of course, now we run into the little problem of, would I actually set myself up, my patient and myself, like this? Probably not. This is not very comfortable for either one of us. I'm kind of having to do this thing to see the trap at all. I have kind of my patient just kind of like facing into my neck and chin, and this isn't a great way for me to get any leverage on the traps themselves. So holding this technique is going to wear my hands out. So what I'm going to have Melissa do here is go ahead and put her arm back in the sleeve of her shirt. We only had it out for the benefit of you guys and being able to see some of the bony landmarks. Flip around. Much like the levator scapulae, I don't have a problem palpating or releasing the upper trapezius through thin gym clothing or even like a t-shirt. Like, there's no reason to have to move around clothing, and I think with a little practice you guys will be able to feel the landmarks enough that you won't need like a visual reference on the skin per se. Now this isn't a terrible way to do it, not my favorite way in seated. You're definitely better off posterior to the patient than you are in front of the patient. You can kind of do the palm the head thing or the headlock thing, although this is going to get a little trickier with the traps, because the way to stretch the traps, and again we're going to add lengthening to these tissues to try to pin down our overactive nodule, right? We want to kind of pull it from either side so that when we press down on it, it doesn't do that flop around thing, right? We have a little support from either side. With the upper trap, the levator scapulae went this way, which is nice because it just kind of falls into our arm. With upper trap, we need to go this way, right? So if you can get your hand on somebody's head, it makes it a lot easier. The kind of headlock technique we talked about before ends up putting you with hands crossed, which isn't going to be real easy. So I can go into contralateral flexion, a little bit of flexion, and then it's ipsilateral rotation, and then I can use this hand to once again strum in this diagonal, right? So superior lateral to inferior medial. Right, so this way, find those tight fascicles, find the tightest nodule, and boom, and you can see Melissa's face change, and that's the tender point. Now, not a terrible way to do this technique, but I'm really not taking advantage of any sort of leverage. I can definitely control Melissa's head, and I can get enough pressure in this position, but I'd prefer something that didn't require so much hand strength from me and maybe stabilized Melissa a little bit more. So what we're going to do is go ahead and do this in supine. Bring the table up just a little bit, so if the table is at about the same height as my elbows, I can then use this hand underneath the occiput, and what I'm going to do is kind of pull her head this way, right, so that as I pull her head, she's rotated in the same direction. Alright, so this would be levator scapulae, letting her fall off this way. That would lengthen those tissues because those tissues connect into the transverse process. Well, since these tissues connect into the spinous process, I want to pull the spinous process away from my insertion. Now once I get there, once again I'm going, it almost works out that like when I put my hand down, the direction of my thumb is going perfectly in that obliquity, that diagonal that I want to strum these tissues. and I'm a little bit more on top of the neck or on top of these tissues than I was for Levator Scapulae, where my thumb was way underneath. Now I'm here. I'm going to look for the most tender spot, which I'm thinking is right about there. Right, so I did my strumming across the fibers, and then I went distal to proximal to find the nodule, and now I'm going to press. And the advantage here, guys, comes from the fact that once I have her in position, I can set my arms down and essentially let the friction between my arm and the table do all the work. Like, I don't have to hold her head up. Once I've moved it there, I can just let my hand rest on the table, let her occiput just kind of fall into my hand, pressing it into the table. With the pressure here, once I have the pressure, I can put my forearm down on the table, and the table prevents me from being pushed out of her upper trapezius. I'm not saying this is ideal. Once again, with cervical dysfunction and working on the neck, it is a little bit more tiring on the hands than some of the other techniques we use. I have seen other videos where individuals work on the traps in prone. My only problem with those techniques is the finger on the marble game. It's very hard to add any length to the tissues in prone. Not impossible, but a little bit more difficult. Stay tuned for the close-up recap. Now for a close-up recap, in this video you can see how this line right here is actually the border of Melissa's upper trapezius. If I pull her into a upper trapezius stretch using that offhand at the bottom of her occiput, that border becomes even more clear. Now I have the trigger point, the common trigger point that is, marked off for the upper trapezius, and you can see how when my thumb comes in, it automatically assumes that superior lateral to inferior medial diagonal that I'm going to use for my strumming, and then I'm going to find the most dense fascicles I can find, and then I can move from distal to proximal to try to find a nodule or acute point of hyperactivity that we're going to assume is the trigger point, so that I can then just lay my arm down and hold this pressure for 30 seconds to 2 minutes until I get a release. I can communicate with my patient. Hey Melissa, how does this feel? Good? Alright, so not too much tenderness, not too much intensity, not too much pain. As it's starting to dissipate. And it'll start to dissipate after 10-15 seconds. You want to hold it until you get a nice complete release. And then you can move on to your next trigger point or onto the next muscle that you've assessed as overactive. So once again, I'm just going to move Melissa into lateral flexion, a little bit of flexion here, and ipsilateral rotation. I'm going to use my superior lateral to inferior medial diagonal to locate taut bands. I'm then going to go from distal to proximal to find a tight nodule, and then I'm going to press in, lay my arm down so that the table is essentially holding me there, and I'm going to hold to get a release. So there you have it. Knowing your functional anatomy will definitely help your manual technique. It'll help you differentiate structures so that you can place your hands where they need to be, as well as make you aware of the sensitive structures around the tissue that you're trying to target. Things like nerves and lymph nodes and arteries. Make sure that if you're going to place your hands on a patient that you have done an assessment and have a good rationale for placing your hands on that patient. And if you're going to assess, make sure you reassess to ensure that your technique was effective and you have a good rationale for using that technique again. Now with manual therapy, one-on-one live education is incredibly important. Please be looking for opportunities like workshops and mentorships and maybe even classes at your local university that can get you some one-on-one individual instruction, or at least some live classroom instruction, so that you've had a chance to be critiqued and mentored by somebody senior to you with some experience in manual therapy techniques. And before you bring this stuff back to your rehab, fitness, or performance setting, please practice on colleagues. There is no substitute for practice, and it is going to take a while to get accustomed to some of the techniques that we show in these manual technique videos. Don't expect to learn them in 2 or 3 or even 5 minutes. You want to have hours of experience under your belt working on various different body sizes and shapes, so that when you do get that first paying client, first paying customer, and you're really trying to make a good positive impact, really trying to promote better outcomes, you feel comfortable with that technique. I look forward to hearing about your outcomes and hearing your questions in the comments section of this video. I'll talk with you soon.